Hello, everybody. Welcome and thank you for joining us for today's National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living and hosted by the American Society on Aging. Today's presentation is Building Partnerships to Scale Effective Dementia Care. We will be getting started in just a moment, but before we do, a few housekeeping notes. Today's slides are available under the tab on your screen located under the Resources tab. There is also a tab labeled CE Application here. That is where you will find information on how to obtain CE credit for today's event. You have 60 days to complete the continuing education application. It may take us up to 30 days from your application date for us to process and issue that CE credit. If you are not logged in directly to this webinar with an individualized confirmation URL, you will be eligible for CE credit as we have no way of tracking your online attendance. You must register with your own email address and watch it under your own unique link. If you have any questions during today's presentation, you can send those to us at any time using the questions box, and we will save the last 10 to 15 minutes of today's program to get to those. And now I will turn it over to Sari Schumann of the National Alzheimer's and Dementia Resource Center.
Great, thank you so much, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Building Partnerships to Scale Effective Dementia Care Support. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome.
Hi, everyone. On behalf of the Administration for Community Living, I want to thank you all for taking time out of your busy schedules to join us today to learn about the great work that the folks in Indiana are doing. I want to thank Stephen Council, Kathy Frank, and Tarek Brown for imparting their wisdom on us today. I look forward to learning from them, as I hope you will as well. And with that, I'll send it back to you, Sari, for get things going. Thanks.
Thank you, Erin. Before we start today, I'll give a little introduction on each of our speakers, and then I will turn it over to them. So today, as you heard, we will hear from Dr. Stephen Council, who is Professor of Medicine at Indiana University's School of Medicine in Indianapolis. Dr. Council was the founding director of the Indiana University Geriatrics Program and recently served as president of the American Geriatric Society. He also serves as medical director for Indiana Family and Social Services Administration's Division of Aging and is the project director of Indiana University's Administration for Community Living ADPI Dementia Care Grant, working in partnership with Indiana's area agencies on aging. We also have with us today Kathy Frank, who is the Geriatrics Program Administrator at Indiana University's School of Medicine. Kathy Frank works with the director of the Indiana University Geriatrics on the coordination, development, and strengthening of clinical care services, education, and research in geriatrics. She also serves as co-director for Indiana University's Geriatrics Workforce Enhancement Program, funded by HRSA, and is project manager for the grant you will hear about today. Tarek Brown is president and CEO of PsyCoa Aging and In-Home Solutions, which is the largest of Indiana's 15 area agencies on aging. Previously, Tarek was COO for Senior Services Incorporated, an agency supporting older adults and people with disabilities in Kalamazoo, Michigan. He started his career in the U.S. Army and then became a successful owner and operator for a multi-carrier wireless retail company. Today, all of them join us to talk about Indiana University's ADPI project that is partnering with area agencies on aging. I'm going to turn the presentation over to Dr. Council to start us off.
Thank you, Sari. I want to start by extending our gratitude to the U.S. Administration for Community Living for their grant support of this project, and to state that we are really honored to have the opportunity to share our work in Indiana with you all today. Our intent is by the end of this presentation that participants will be able to first describe how Indiana University, or IU, partnered with 5 of Indiana's area agencies on aging, or AAAs, to scale a dementia care program developed and tested at IU. Second, to list 3 key elements of the IU-AAA partnership leading to successful program implementation and process improvement. 3, to identify 3 reasons why AAA has partnered with IU to launch a dementia care program. And finally, to discuss plans for sustainability and statewide expansion of the IU-AAA dementia care program. I will kick things off by discussing how we first developed the University AAA collaboration, key aspects of our dementia care program, and preliminary results. We're a little over 2 years into our project titled Strengthening and Expanding the IU-AAA Dementia-Capable Home and Community-Based Services, or HCBS, system. Noteworthy here is that we were awarded a federal grant through ACL of $1 million, but $333,333 needed to come as a match. And this was provided by the 5 area agencies on aging. The point being here that the area agencies on aging were engaged from the beginning, collaborating on the grant proposal, including both the program plan and the budget. The cornerstone of this University AAA collaboration is the longstanding partnership with SACOA. Through mutual involvement in the Indiana Dementia Care Advisory Group, we identified a shared goal as follows: to enhance, strengthen, and expand the existing IU-AAA dementia-capable HCBS system to maximize the ability of people with Alzheimer's disease and related dementias to remain independent in the community. We had 2 primary objectives under the grant, and we'll focus on the first one today in our presentation: to provide a dementia care coach support to persons living with dementia and their family caregivers. As I mentioned, this grant was to enhance, strengthen, and expand the existing IU-AAA programming. So our existing partners under the proposal was, first and foremost, SACOA Aging and In-Home Solutions, the largest area agency on aging in Indiana, covering central Indiana, Marion County, and surrounding counties. And in addition to being the area agency on aging, they're also the Aging and Disability Resource Center. The focus of our project was on members of the Asian Disabled Waiver Program. So under Medicaid, they fund in-home long-term services and supports for people who are nursing home level of care, but who are trying to reside at home or in the community with supports. So this, as you might imagine, has a large proportion of people living with dementia, and the care management is provided by the area agencies on aging for these waiver participants in our state. So the existing partners was the IU Geriatrics Program, Center for Aging Research, and Center for Health Innovation and Implementation Science. And then one of the largest safety net public hospital systems in the country, Eskenazi Health, and the Sandra Eskenazi Center for Brain Care Innovation, and several surrounding community health centers affiliated with Eskenazi Health. We also have a IU Geriatrics Workforce Enhancement Program and a close partnership with the Indiana chapter of the Alzheimer's Association. So how about the new partners that were to help us enhance, strengthen, and expand dementia-capable home and community-based services? Well, first is with the state, the Indiana Family and Social Services Administration, and Division of Aging, which had a very strong emphasis on dementia and caregivers under the Indiana State Plan on Aging. And again, our focus is around the waiver program, the Asian Disabled Waiver Program, of which there's about 1,000 participants in the state of Indiana. And we first really collaborated on envisioning this project as a part of the Indiana Dementia Care Advisory Group. We identified 4 additional area agencies on aging and also have involved a close new partnership with the Indiana Association of Area Agencies on Aging and Dementia Friends Indiana, which is led by SACOA and the Area Agencies on Aging statewide. This is just a picture of Indiana and planning and service areas covered by the 15 different area agencies on aging. One of the area agencies on aging covers 2 areas. You can see that SACOA there is area 8 in the middle, and those 8 counties. And then Real Services, Aging In-Home Services of Northeast Indiana, LifeStream Services, and Thrive Alliance there from top to bottom. All told, we cover 34 of the 92 counties in Indiana, and about half of the waiver participants are managed by these 5 area agencies on aging care managers. So what are the key aspects of our dementia care program? Well, first, as I mentioned, we're focusing on people enrolled in the Asian Disabled Waiver program and having dementia and supporting their family caregivers. About 30% of waiver participants have a diagnosis of dementia. Second, we're delivering the intervention through care coaches. We have 1 care coach employed by each of the 5 area agencies on aging, and they partner with the waiver care managers at their respective area agency on aging. They are community health workers of sorts with at least a high school degree, and they start out with an intensive 5-day dementia care training put on by IU and SACOA dementia care expert trainers. This is complemented by every 6 months a 2-day booster training for the care coaches, as well as regular dementia care case conferences covering particular cases and challenges in their day-to-day work. So what's the intervention? The primary intervention is termed the Caregiver Stress Prevention Bundle. This is an evidence-informed intervention adapted from the Aging Brain Care Collaborative Care Program, which is referenced at the bottom there with a link to the best practice caregiving site describing this program. This is a medical program that has been proven to decrease caregiver stress and reduce dementia symptoms. We have, under this project, translated this intervention for scalability by deploying community health workers as care coaches. The Caregiver Stress Prevention Bundle includes 4 key components. The first is caregiver counseling, education, and referral. This is around communication skills, behavioral symptom management training, caregiver coping, and multiple other issues that come up in the care and support of a loved one with dementia. Second is developing and documenting crisis plans. So if the caregiver has to go to the emergency department or gets ill, what happens? And that's spelled out ahead of time. Third is scheduled weekly caregiver time off from their caregiver responsibilities, ideally 8 hours off each week. And then finally, monthly caregiver support group participation. The care coaches assess and monitor the people living with dementia and their caregivers using the HABC monitor, a healthy aging brain care monitor, also developed by researchers of the IU Center for Aging Research. This is a practical, user-friendly assessment tool Scores range from 0 to 93. The lower score is better, for less caregiver stress and fewer dementia symptoms. You can see that the green zone is a score of 0 to 14, and that's our goal, is to get people to the green zone and help them stay there. We can talk more about this tool in the question and answer period if desired. So how does this work? Well, the process flow is at the Area Agency on Aging. They identify their waiver participants with dementia and their caregivers. And then the waiver care manager offers the care coach and program enrollment. The care coach then engages with the participant and caregiver, and they use the HABC monitor to initially assess and then monitor over time both dementia symptoms and caregiver stress. We require as a part of the program that the care coach visits, but usually with the caregiver, at least at 1, 2, and 3 months, and then quarterly. But this all really depends on and is focused on the person-centered principles with the caregiver in this case, with extra visits provided to achieve goals and to deliver the full Caregiver Stress Prevention Bundle according to the individual needs of that caregiver. There are weekly huddles by the Area Agency on Aging waiver care managers with the care coaches to discuss cases in an ongoing manner. So the CEOs and executive directors of the Area Agencies on Aging and related organizations in red here really form the foundation of this steering committee that we have. And one of the roles of the steering committee here on this slide, right first and foremost, letter A, substantive involvement in the planning and implementation of the project. And you can see at the bottom, we had under this project a 6-month planning phase before implementing the program. We managed our project with 3 teams: the IU project team, the management team. This was led by Dr. Kathy Frank, who will be speaking after me. And this includes notably a project site coordinator from each of the 5 area agencies on aging. I want to stress again that the key to our successful university and area agency on aging collaboration was working together to both develop and implement the project toward shared goals to better serve people living with dementia and their caregivers. So as examples, the area agencies on aging and the university worked very closely in developing each of the processes, right from identifying waiver participants with dementia and how to communicate initially both internally and externally with the caregivers and such, and how to document their plans. And then implementation kicked off, and as Kathy Frank will describe further, help with care coach hiring and orientation and training, and working towards better collaboration with waiver care managers and beginning the dementia care case conferences. So where do we stand at this point in time? Just a brief status check. At the end of June, we had enrolled 339 participants and their caregivers. And at the end of June, active still in the program were 209. And you can see that they're distributed across the 5 different area agencies on aging. On the right-hand side is the baseline HABC monitor scores. And you can see that 31% there at the top were already in the green zone. So the focus there was to prevent caregiver stress. But for the others, you can see that we had a pretty broad distribution with some scores getting pretty high, representing high caregiver stress levels. And then at the bottom right, we just we keep track using the dashboard that we are delivering on the key components of the Caregiver Stress Prevention Bundle, activating the protocols through counseling and education, developing crisis plans, helping people have scheduled caregiver time off, and getting involved in caregiver support groups according to what they see would be helpful to them. So preliminary results, we have really been pleased with the results even at 3 months following initiation of the Care Coach and the Caregiver Stress Prevention Bundle intervention. The HABC monitor, again, assesses but also tracks outcomes, the beauty of that scale. And so it has several subscales, which then added together develop our measurable outcomes that are bolded to the left: caregiver stress, caregiver quality of life, dementia symptoms, and participant or person living with dementia quality of life. The key point here is that we are seeing already at 3 months clinically and statistically significant improvements in these scores. My last slide shows the average HABC monitor scores over a 12-month period in those caregivers that we've been serving for 12 months or more. You can see that the average score at baseline was about 20 and then came down within the green zone at 3 months and then has remained there. All this being consistent with the goal of the Caregiver Stress Prevention Bundle intervention. I'll now turn this over to my colleague, Dr. Kathy Frank.
Good day. Good day. Thank you, Dr. Council, for that presentation so far. It kind of helps build the base of what we're talking about today. My role as project manager is really to help make it happen. So that's kind of why I'm going to focus today on implementation and engagement strategies. So these are the 3 things I hope to accomplish with you very quickly here is what our process was, what our ongoing support is for our AAA folks, and also what our team approach is to addressing challenges. As we all know, we have them everywhere, so better figure out how to deal with them, right? So to get started, we began with meeting with our teams and our AAAs because we believed this was really a team sport. So we focused on leadership and working on reviewing our plan and what we were going to accomplish, creating a job description for the dementia care coaches, and then began figuring out how are we going to track this and document this and keep track. So we have processes within the CAM system there with the AAAs. We also utilize the REDCap system. It's a data system at IU on how to collect our data. And as Dr. Council shared, we have dashboards. So the first part was hiring. Of course, this was done virtually for the most part due to the pandemic. And so we worked with the HR departments of each of the AAAs, worked on the standardized interviewing process. But we added a little step to this, and that was a second round of interviewing, again, done virtually, where each of the candidates had to complete and go through the process of really discussing dementia scenarios. And we had several of those in a PowerPoint. And the next slide just gives you one example, because our goal really as we hunted for the right persons to be our care coaches, we wanted folks that not only had a passion for caring for older adults, but also a passion for how to really focus on dementia and the caregivers, and that was our big focus. So the scenarios, such as the one that you see in front of you, was really just setting the stage of here you are, you've got this family, and you've got dementia, and you have this caregiver, and what are you going to do? So it gave us some insight also into the candidates and what extra training we might need to provide for them as well. And they had several of these scenarios. Second was then to begin focusing on getting them oriented and ready to be a care coach. So we had to work on checklists, we had training, with Dr. Bustani and with Cassie, our excellent social worker lead from SACOA and the Healthy Aging Brain Center. We focused on templates and how to really do the CAMs and how to really work on REDCap, because that was new to all of them. And we really felt like the CAMs piece was very important to have documentation in one place so the care managers, case managers could also then keep up to date with what's happening with their clients. Another thing that we created was success stories, and we really wanted folks to take a moment to celebrate. We do this on a regular basis where all the care coaches share their success stories, not only with us, but with each other, and we've learned to work together to really enjoy the progress we're making. The other two pieces that we have added to the orientation process were, one was to really focus on empathetic listening skills, because doing this especially by phone, it was just really important that they be able to understand how to listen, validate, and really focus on what the caregivers' priorities are. We focused on what matters most to caregivers. And then the last piece was a wonderful little book called The Fred Factor, and that was for us to grow Freds, because Freds do an awesome job and they're above and beyond the call and do an amazing work. Our second piece then here was to begin working on our meetings. So we had management team meetings. We met really every week for a while till we got settled. We now do it twice a month. And we have a pretty big agenda every month because we want to focus on past meetings and what our pending action plans are. We also talk about our numbers. We review our dashboards, and we talk about our work plan expectations. And really, it's really a time for us to grow together and be a team together, even though, again, we're doing this virtually. And then right after those meetings, we have the care coaches join us, and we focus on cases and situations. Again, the care case conference time was a time not only to brainstorm and figure out how to deal with these situations that they've come across, but also how to be supportive to each other. The care coaches were awesome. They focus on helping each other. They reach out to each other when they have questions or have ideas on coming up with some creative ways to help these caregivers. And we really focus on them paying attention to what are the needs and how might we help. And they love doing it. And then, of course, we also share our success stories at the same time. So we don't just focus on the hard part, but we also celebrate, which is very important. We do have booster sessions, as Dr. Council shared with Dr. Bustani and with Cassie. And this piece is really an excellent opportunity for care coaches and their project site coordinators to really reflect on what's been happening and what are the challenges and what are the successes, and how they might really think about the engagement of this program in other places as well. So team approach is critical, and we continue to help the care managers, case managers, whichever way you call them, to really be a part of our team, because they're the ones that have these clients and work with these caregivers already and know about our care coach program and can help introduce and really decrease the time it takes to become engaged in partnering with the caregiver. So we did have talking points to help them. We've developed video recordings to help care managers know more about the program. And occasionally care coaches are asked to join those calls and actually work together in helping to explain what this opportunity is for the caregivers. So the last part really is about how to deal with our challenges. We all have them, and Dr. Council said we have a dashboard. We review it on a regular basis, and I had to really help people understand it's not really a report card. No one's getting chair time. It's time to look at where we've been, where might we be going, how might we get there. And so one of the things that I helped create was a way to look deeper into our dashboards and really focus on quality improvement and what might we do. So each of the project site managers at the AAAs take their dashboard and they review the tracker for the dashboard. so that they can dig deeper and think about, oh, well, we did this. Well, no, we didn't do this. Well, the goal really is to brainstorm about what could we do different and how might we make this work more successfully and engage more people. And it's an easy tool. They do it every month, and they come up with some great ideas, and they share that with their peers at management team and at care conference as well, and really find ways to enhance our program to be implemented more effectively. The other piece that we do, in addition to the dashboard tracker, is a tool that I created called the Completed Visit Tracker. And this tool takes the information out of REDCap and makes it into a workable kind of treatment sheet so that they can look at where their clients are, what needs to be happening, who's next to be visited, what's their score, what else do we need to be doing, paying attention to if we've missed a visit, and we've been able to also then identify ways to improve things. And it's been amazing to see how missed visits have declined, pending visits are happening, HABC scores are going down to the green zone, which is just exactly what we're looking for. So that just gives you a little picture of what it's like to try to implement this model. So at this time, I'm going to turn the speaker over to Tord Brown from SACOA to talk about what it's like from the AAA perspective.
Thank you so much, Kathy. I appreciate it. So I'm going to be talking about the AAA Aging Commitment and Vision. The innovative approach of leveraging the Healthy Aging Brain Center assessment to gain a baseline of caregiver stress levels helps determine what elements of the Caregiver Stress Bundle is appropriate. The red, yellow, green visual reinforces for caregivers if levels are coming down, staying stagnant, or going up. This approach has resulted in stress reduction within 30 days. Alzheimer's dementia services and supports are generally extended to the individual with the condition, but really don't take into account that family caregiver. And as I think about that statement, I reflect on my father-in-law's journey with vascular dementia several years ago, and how much a program like this would have benefited my wife as she was walking through that journey with him. I wasn't really able to help her, guide her through certain things, understanding how the condition does have an impact on her as the caregiver. And so I just wish there had been something like this, services and supports specific to the family caregiver that are funded or available in a cost share or private pay scenario. And I think back and go, gosh, I wonder how much more support, how much smoother that journey would have been for my wife. The results of this program thus far have proven there are innovative and sustainable solutions that are available and make great impact on family caregivers overall that we hope to be in a position to continue this work beyond the grant period. And so one thing I always like to talk about is sustaining a project and expanding a project. And when I talk about low-hanging fruit, it's really to think about the funding streams that you already have at your disposal as an area agency on aging or as, another community business organization, to see if you're able to leverage any of those funding streams to enhance or to sustain this work. One example specifically deals with Older Americans Act funding. AAAs are the trusted, innovative, and dependable organizations that are charged to plan and develop services designed to keep older adults 60 and above thriving independently in their own homes. As such, we could certainly think about funding titles under Older Americans Act and see if funding could be expanded for a specific offering like this. We have the data to prove the concept, and we know there is a demand for this service, so we should explore it. We all know that health plans or managed care entities work with many of our AAAs across the country already, So could this be something that they might be willing to take a look at and fund as a way to expand and sustain this offering? We also know health systems work with many of our area agencies on aging nationally as well. So again, I see this as an opportunity. Large hospitals, physician networks, acute care organizations, etc. 10 years ago, when I started in the aging industry, I remember thinking, if an entity pays you money to provide a service via publicly funded resources, then wouldn't an individual in need with the financial ability to pay for that quality service do so? Cost share and private pay is a wonderful opportunity to begin building your business to consumer programming. And then lastly, we can't forget business to business opportunities other than what I've mentioned here. There could be other industries, maybe that sit on the peripheral of healthcare in general, that might have a desire to become a business customer of a program or service like this. In addition to that, many of your larger employees or employers in your states may see a value in contracting with your organizations for these kinds of service offerings for their employee base as an added perk of being an employee of that particular employer. And so in summary, let me close by saying we hope that we've demonstrated the high demand for services and supports directly for the family caregivers of loved ones living with Alzheimer's or dementia as they walk this two-person journey together. As I said earlier, I think about my father-in-law, and when Bob was going through his vascular dementia journey, my wife and her sister were walking right alongside with him, but I look at it as they were walking blindly. They really didn't have this kind of program available to them to really contact a trusted organization and help them provide those emergent services and resources to them to help keep their stressor or burden levels in the green zone. So thank you very much for your time, and I'll turn it back over to our moderator.
Thank you so much, everyone, for your great presentations. We will move to questions now that all of you can put into the question and answer chat pod on your screen. A few have already come in, so we will start with those. And I'll go back and forth between to make sure you all have the contact information. I will do the contact information up for a few minutes while you're entering your questions. We'll start with a question, Dr. Council, for you. If you can talk a little bit more about caregiver time off and how it initially was decided to include caregiver time off and how receptive are participants to taking that time?
Thank you for that question. Yes, that's really important and actually viewed by the researchers and the people who developed this program as probably, excuse me, one of the most important aspects of addressing right up front. As this is challenging to do, but it's proven to be so beneficial to the caregiver over the long run. So as a key component of the 4 components of the Caregiver Stress Prevention Bundle is regular caregiver time off to give them relief from their caregiving responsibilities, to tend to themselves and their own health and their own social connectivity and such. So that has been proven to be very beneficial in studies and different interventions that have looked at reducing and addressing caregiver strain, and thus was decided to be a key part of the Caregiver Stress Prevention Bundle. And as I said, that program, especially in the medical model, has really shown to work consistently across several studies. I think what was new here was having a community health worker or someone from the Area Agency on Aging be the support person instead of a nurse or a social worker. That might be more typical in some of the more medical collaborative care models. The caregiver time off can be obtained through multiple avenues, and one is just starting with identifying the need and helping the caregiver understand and realize and become more aware and self-reflective on how that can benefit from them, rather than just one more thing to try to schedule or to find coverage for. And then whether it can be from other friends, family that oftentimes may not get engaged unless asked. But if they are asked, they may go ahead and provide support. So that's the first avenue. Secondly, there are services that the Waiver care manager can help connect. And this is another critical point of collaboration between the care coach with the care manager to identify waiver services that are, provided under Medicaid funding to help provide respite. For example, maybe the person could go to adult day services for a day a week and giving the caregiver a day a week off. Or maybe they could have an attendant care, personal care worker come in one day a week. So those are other options to go wild and troubleshoot between the caregiver, the person living with dementia, the care manager, and the care coach working together.
Great. Thank you so much for that. Kathy, can you talk a little bit about the care coach caseload and how many clients a care coach may have at any one time? I know that there may have been some fluctuation in that, over a year or so, but if you could talk a little bit about, the maximum amount of clients and about how much time and effort each one takes, that would be helpful.
Sure, be glad to do that. It has waxed and waned depending on enrollment and also depending on folks who do end the project early. We've discovered that we've had several folks that have passed away, have died during this process. So I think sometimes we're getting them near the end of their journey instead of at the beginning. And then some of them are just so overwhelmed. Sometimes they have to, take a break from us for a while, and then they come back. But the care coaches, I would say on average, probably are up to probably 50 or so clients now. We'd like to see that get a little higher, maybe up to 100, because they're not traveling. It's all virtual. The biggest challenge I think care coaches have is scheduling the time and being able to reach out and connect. They use text, they use email, they call, they mail things to the caregivers. So trying to find ways other than, in person, although they have started doing a little of that now since things have calmed down. But I think the most important piece is they don't limit their time on the phone. They really spend time listening and paying attention to what are the needs, and also spend time teaching. They have a lot of handouts and protocols that they work through to help educate the caregiver and help embrace them and how to understand what's happening. So hopefully that helps some.
That's great. Thank you so much. Can one of you talk about the actual administration of the HABC monitor? How does it actually measure caregiver stress with the 4 questions that you talked about? And can you talk a little bit about the method of administration as well?
Yes, I can cover that. The HABC monitor has about 24 questions, And the 4 subscales that were on a prior slide. One is the cognitive subscale that looks at judgment of decision-making, repeating the same things over and over, remembering appointments, and the like. A functional subscale that looks at, is someone walking or needing help in ambulation, bathing, shopping, taking medications. Third is a behavioral and mood subscale. And this is the one that measures particularly the dementia symptoms. And some important ones there are feeling down, depressed, or hopeless, being stubborn, agitated, aggressive, or resistive to help from others, feeling anxious, nervous, tense, fearful, or panic, falling asleep, staying asleep, or sleeping too much. These are important symptoms and behavioral issues often coming into play. And then the final scale is around caregiver quality of life and really asks about their mental health and physical health as well as their financial future. So all subscales are used to develop the caregiver stress scores that we like to see 14 or under in the green zone. Just the behavioral and mood subscale is the one that measures the dementia symptoms. And so this can be administered in a matter of minutes and asks, if they have the issue, not at all, several days, or more than half the days in the last couple of weeks, or almost daily. And so it's a nice tool to assess where things are, but then also monitor and see if things are getting better. It's been readily validated and found to be a reliable measure of caregiver stress compared to other research-based tools, and does demonstrate change over time, because we know that things change, and this is one important aspect of the Caregiver Stress Prevention Bundle program, is it's a continuous, ongoing support. It's not a 3-month, 6-month and out, but it's but realizing that issues change over time and the support needs change over time. The care coach can back off if they're in the green zone and all is good, but be at the ready and have a trusting relationship already in place if something comes up that is new, such as a new behavior or a new issue in their lives together. And so this is part of the beauty of really person-centered intervention that addresses the needs of that dyad, both the person living with dementia and the caregiver.
Great, thank you so much. A follow-up question is just asking if the HABC measure is available anywhere that people can take a look at it. If you have a link for that and want to send it out to me, I can send it out to the participants.
Yes, for sure. It's as I say, it's a well-studied and researched tool. So yes, we'll get that to you so that you can make that available. Great.
Kathy, we had a question about the FRED factor. Can you talk a little bit about what that means and the implementation surrounding it?
Sure, I'd be glad to. It was not part of the original study. It's one of my management tools that I use. It's a little book, bought one for each of the care coaches, and put a little PowerPoint together, and there's some videos, and really just to take time out and think about the way we think about our jobs and how to be above and beyond and to be extraordinary and not just be, humdrum, so to speak, and to show how much we really care and are concerned about others. So Fred Factor is a book that Mark Sanborn wrote, and it's about his mailman who was named Fred. but he was a very unusual and above and beyond the ordinary mailman. So it's a great little book. There are videos as well. And it just gives us a moment to take time out and think about who we are and how we do our job and how might we be, the very best we can be at it. Hopefully that helps.
Great, thank you so much. So when you are implementing the Caregiver Stress Prevention Bundle, can you talk a little bit about how the intervention takes into account the progressive nature of dementia? And if
yes, I can take that too. It very closely relates to the HABC monitor in terms of it monitoring how things are either progressing or getting better or new things that come up over time. And so that's a part of the elegance of that tool, is that it does take that into account. Primarily the measure when asked the questions to the caregiver is whether or not the issue is causing stress or not, or is problematic. And so over time, even if the symptoms may be getting worse, if the caregiver has developed coping strategies, communication skills, or ways to approach the problematic behavior, that they may not say that it's causing a big problem or not. So it's really a tool that does include that progression over time, but within the context of the caregiver's experience and perception of how things are going.
Great, thank you so much. So another question came in about what are the sustainability plans for this program? I know, Tarek, you talked a little bit about that. Can you delve into that a little bit more and talk about how SICOA may be able to sustain this project into the future?
Yes, thank you for that question. Here at SICOA, we're constantly thinking about ways to diversify revenue. And as I started out in my section, I talked about low-hanging fruit. And so, throughout this grant period, we've been kind of exploring what that might look like. In other words, on our next iteration of our area plan, we certainly want to have this as a focus area in our 8-county region. And so I think that is obviously one opportunity to maybe sustain and expand it a little bit, leveraging some of those older American Act resources that could be available out of Title III-E, which has more to do with caregiver supports and things of that nature. I think beyond that, it's to dream as big as you want to. And that's why I mentioned some of the business-to-business, business-to-consumer opportunities with health plans, with health systems, et cetera. When I talk about business-to-consumer, we're all consumers of products and services, and we think about bundling things together here at SICOA, because our approach is the stickier that older Hoosier is to our organization, the less likely that they're going to need to go elsewhere to obtain the resources and emergent services that they require. So one example of that might be designing a fee-for-service or private pay care management offering. That does include with it some caregiver supports and, specific to caregivers dealing with individuals with dementia or Alzheimer's, as a way to kind of bundle that into the care management offering. If you're doing transportation, that would be great to have in there as well. So we look at things from, very much from that holistic lens of we have to bring more than one thing or more than two things to the table for our consumers to really remain sticky to us, that that trusted, dependable organization that we are. And so, when you have that mindset and that thought process, there really is not a limit on the kinds of things that you might be able to put together for a fee-for-service or private pay offering. Each of these things are a way to help sustain and expand offerings to your consumers beyond a grant that you may have received to do specific work in the caregiver space.
Great, thank you so much. Dr. Council, Kathy, would you like to add to that at all about sustainability?
Yeah, I can pitch in here. I think that's really well covered by Tarek Brown there, and especially, with his perspective from the Area Agencies on Aging standpoint. Something that was really projected right from the beginning in the development of the program was sustainability through the Asian Disabled Waiver Program, the Medicaid HCBS, program, as either a waiver service, a new waiver service that would support that waiver participant and their caregiver in dealing with dementia supports, with a goal to improve quality of life for both, and also help the person, remain in the community as opposed to institutional care, which some of these programs have been shown to help prevent or delay nursing home placement. So as a new waiver service could sustain the program, and closely related to that would be to couple it with the care management service under the waiver. Everyone in the Asian Disabled Waiver gets a care manager, and that currently is primarily through the area agencies on aging. And so if we could have a tiered care management program where currently everyone's paid a flat fee for that care management service at each area agency on aging, but you could have different reimbursement to the AAA for care management of a person with dementia, a waiver participant with dementia, versus someone without dementia. And the tiered payment for the person with dementia would include reimbursement that would cover the Caregiver Stress Prevention Bundle program.
Great, thank you so much. I believe that's all the time we're going to have for questions today on this topic. I want to thank all of our presenters again for this excellent presentation. And we really appreciate your wisdom, as Erin mentioned earlier in the session. And thank you to all the participants for joining us today at the National Alzheimer's and Dementia Resource Center webinar series. Our next webinar will be announced shortly, so please stay tuned to your email and sign up for the ACL e-news to be alerted to our next event. At this time, I will turn things back over to Julia Burrows for some final remarks.
Thank you so much. This has been such a wealth of information, and what an incredible program you guys have, and just really fascinated by the model and the impact that you're demonstrating. So thank you so much for your time. Again, if you would like to claim CEUs for today's webinar, you will be receiving a follow-up email by the end of the business day that will contain a link to the CEU application. There will also be the presentation slides as a PDF attachment to that email. You can follow up with today's slides and that CEU application within 60 days to apply for those CE credits. It may take 30 days for us to process and issue those CE credits. If you have any questions about that, please feel free to reach out to our team at ASA. Thank you all so much for joining us again today, and we hope to have you join us again soon. Take care.